Cardiorespiratory fitness, or CRF, reflects the integrated capacity to perform physical work using oxygen transported from the atmosphere to the mitochondria. Since the late 1950s, numerous scientific reports have examined the relationship between CRF and health outcomes among various populations. However, to date, limited studies has been conducted on the association between CRF and mortality in patients with chronic kidney disease, or CKD. I am Dr. Xunmei Sui, an associate professor in the Department of Exercise Science from the Arnold School of Public Health, University of South Carolina, here in Columbia, South Carolina. I am here today to discuss our new paper entitled Cardiorespiratory Fitness and Mortality in Patients with Chronic Kidney Disease, a prospective cohort study, which will be published in an upcoming issue of the Journal of Mayo Clinic Proceedings. I'd first like to acknowledge and congratulate the excellent effort of our research team, including Dr. Peter Kokinos, Dr. Carl Levin, Dr. Jiajia Zhang, Dr. Jonathan Mayers, and other co-authors throughout the processing and the review of this manuscript. We assessed a large cohort of United States veterans, over 750,000, and eventually identified 45,674 men and women aged 30 to 95 years who all completed an exercise treadmill test, or ETT, within the Veterans Affairs hospitals across the United States. So they all were diagnosed with CKD before the exercise test by International Classification of Disease 9th and 10th revision codes. Age and sex-specific CRF categories were established based on the peak metabolic equivalent, or METs, achieved during the exercise test. During nearly 16 years of follow-up, 53.2% patients died. The association between CRF and mortality risk was inverse and graded. When risk was assessed across CRF categories, using the least fit category as the referent, those in the low fit, which is the next lowest CRF category, had a 24% lower risk of dying. The risk declined progressively with increased CRF and was 67% lower among patients in the highest CRF category. We further found that the pattern of the CRF mortality risk association was similar across age, sex, or race groups. So basically, CRF is protective from all-cause mortality in both men and women, in those younger than 65 of age, and those 65 or older, and for all races, whites, blacks, and others. For each 1 MET increase in CRF, the adjusted hazard ratio for mortality was 12%, which means that every MET increase in patients' CRF level, their risk of dying was 12% lower. To the best of our knowledge, this is the first study to report an inverse association of CRF with mortality within subgroups of men and women, older and younger adults, and multi-ethnic populations across the spectrum of CKD. These findings have a very important clinical implications, suggesting that improving CRF in patients with CKD will have beneficial effects on their overall survival. So there are already evidence that CRF is protecting against cardiovascular disease, certain types of cancer, and mortality, not only in healthy populations, but also in patients with CKD. We all know that impaired CRF is prevalent in patients with CKD. However, randomized controlled trials have shown that CRF can be improved through exercise training in CKD patients. So we believe that clinicians should counsel and encourage their patients to adopt and maintain an active lifestyle. Indeed, the American Kidney Foundation recommends that people with CKD engage in at least 150 minutes of moderate intensity aerobic physical activity weekly. For example, brisk walking, swimming, or generally increasing activities of daily living, or to a level compatible with patients' cardiovascular and physical tolerances. Thank you, and I hope this information is helpful.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com/Mayo Proceedings, or journal updates on Facebook, www.facebook.com/Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.